Hello, this is Aaron Saft on the MR Runningpains podcast. With 30 years of running experience and 20 years of coaching, I thought it time to share with you things I've learned and people I've met so that you can try things for yourself and see if they help your running. Thanks for joining me.
Wrote this song while crewing Aaron on a 100-mile foot race through the trails in the rain and mud. How about that? Miles to go. 100 miles to go. Don't ask me why I do it, I don't know. Miles by foot. 100 miles by foot. Don't ask me why I do it, I can't stay put. Rain is a coming, can't give a fit. Rain is a coming, can't give a fit. Don't ask me why I do it, but I am legit.
Well, today's episode is with Kyle Judkins. Kyle is a family and sports medicine physician. He is also an osteopathic doctor, or a DO. Kyle went to the Virginia College of Osteopathic Medicine, which is where my wife actually went, and so I have a lot of dealings with osteopathic medicine, obviously, having my wife as a family physician, and so I understand the profession a little bit more. But it's great to talk to Kyle, and we can share that information with you guys, so you know what osteopathic medicine offers to everyone, and in contrast to the allopathic medicine or your MD. They're both doctors, and Kyle helps us distinguish the two and what osteopathic medicine has to bring to the table. So really enjoyed this conversation with Kyle. We got into some stuff and talked about some personal experiences and such. So, nice, great conversation, very informative. And that's kind of what I want to bring to the table with this podcast. I feel like this podcast is a great way to share and disseminate some information, and hopefully make your running as best as it can be. You know what resources are available to you and what those resources can do for you. So if you have ideas for guests you'd like to hear from, or professions you'd like to learn about that can help us in our running journey, please just reach out and let me know. I've really enjoyed a lot of these conversations. I've learned a lot, obviously, and I hope you are as well. Had a great vacation last week. Hopefully you enjoyed, you parents and others that are thinking about kids, enjoyed the conversation I had with my wife on the last podcast. I really enjoyed talking with her. It was definitely tough to get her to come onto the podcast. She's very modest and doesn't like to share her thoughts or be heard or talking to a microphone. So again, I really appreciate her coming on. Running has been going okay. This thing that's going on with my hip, my wife kind of thinks that it might be a permanency of just the way that over time my body has kind of dealt with running. Hopefully it's not the case that it's going to come and go, but still working on strength training, doing my physical therapy. I'm adding back in some of Jay Dicharry's workouts. If you're familiar with Jay Dicharry, he's got a great resource in the book Running Rewired. If you don't have that book, you should put your hands on it, put it into your library. It is a great resource, not only for strength and core training, but plyometrics and dealing with strengthening weaknesses and injury. Just a fantastic resource for all runners. So that's Jay Dicharry, Dicharry, and the book is Running Rewired. Really love that book, and I use it with a lot of my athletes. We do the hip circuit quite often, and you can find the hip circuit on YouTube if you just search Jay Dicharry hip circuit. That will come up. It's a fantastic routine. I'll be doing it today. I'm recording on Wednesday, August 19th. This intro, and it's on my schedule for today. So I not only assign it, but I do it myself. I believe in it. It's definitely a great way to strengthen. But we've been really listening to other podcasts and stuff, and I'm just realizing the value. I've said it in the past of doing all of the ancillary and doing a little bit of core each day. I'm trying to include a little bit of plank work each day if I'm not doing strength work. But yeah, after each run, I'm stretching and foam rolling. I'm doing my banded warm-ups. You can see my banded warm-up on YouTube. There's also David Roche's YouTube banded warm-up. That's a great routine as well. And I use a band called Spry. I think it's SPRY, and it's the Zircluff, I think, XRCUFF. You probably only need the yellow or the green bands, but they're great for those warm-up routines and kind of doing some of the stuff that's in Jay Dicharry's book. You can also just use the TheraBand. I think in some of my videos I'm just using the TheraBand, but I'll make a link in the show notes about those resources. Running, it's just great to be running again. I'm going to be working on my aerobic base. So if you see me on Strava, just doing some 45-minute runs, an hour, maybe an hour and a half every here and there. I'm really going to work on my aerobic base and getting that back. I can tell, just watching my heart rate, that, it's definitely, I need to work on that aerobic base and kind of get back to fitness in that regard. I kind of talked about that in the previous episodes as well, but it's need to work my way down. I've been off for about a month, so I've picked up some extra weight from not running as much, which is not helpful. So hopefully I'll cut that back as well. It's just great to be running again. Nice to get out there, each day and just kind of go for whatever it is, half hour, 45 minutes. I'm just grateful for that. So, it's coming up on September. That's crazy. I can't believe it. We've got next week, and then it's going to turn into September already. So my September newsletter will be coming out. If you want to subscribe to that, you can go to my website, mrrunningpains.com. I'll put that in the show notes as well. But the newsletter has just been getting bigger and bigger, including more and more information, tips, reviews, just anything I can think of that has to do with running and helping you in your journey. So subscribe to that if you would. the YouTube channel. I've added kind of a post-run stretching routine that I've had since college. I'm going to do an alternate stretching routine as well, but that's up on there. I included also a video from the Hill Plyometrics that Lydiard suggests. And that's something that I'll be doing after my aerobic base. I'm going to spend a while here, a number of weeks, 10 to even 12 weeks here in the aerobic base phase, because I'm not in a rush for anything. But after that, I'll be working on the hill, and the idea there is to work the skeletal muscular system and catch that up, because we've worked cardio for so long that we need to kind of catch up the musculoskeletal system and make that stronger and fitter and prepared for more training. Hopefully reduce the risk of injury. So that video is on there. If you have questions on how to incorporate it after watching the video, of course, just reach out. So far as coaching goes, I do have a few spots. It's kind of that time of year where people are transitioning in and out. So if you're looking to kind of get started and kind of some guidance on how to get ready for 2021, where hopefully races will be coming back, don't hesitate to reach out. We'll start working on your aerobic base, and you can join my journey in trying to get fit and ready for 2021. So please, send me an email, runningpains@gmail.com. You can go through my website, mrrunningpains.com. Appreciate you guys listening. I hope you enjoy this conversation with Kyle Judkins, and I'll talk to you at the end. Hey, everybody. I'd like to welcome to the show today Dr. Kyle Judkins, DO and CAQSM. Now, we were just talking before the show here about CAQSM. I had not heard that an acronym. Kyle, what is that?
Yeah, so thank you for having me on, first of all. I appreciate it.
Absolutely.
So CAQSM is just the Certificate of Added Qualification in Sports Medicine. So it's the certificate that you earn when you do a sports medicine fellowship after residency.
And we're going to be talking about that as well. Kyle went to the Virginia College of Osteopathic Medicine, which is in Blacksburg, Virginia, right with Virginia Tech. That's where my wife went. So really cool place. He is a doctor of osteopathic medicine. That's where the DO comes from, doctor of osteopathic. So first thing we want to hit you with is, what is osteopathic medicine, and how does it differ from allopathic medicine or MD?
Yeah. So I believe, much like your wife, I'm a bit of a nerd when it comes to osteopathic medicine.
I think I'm my wife. I didn't say that.
I actually, just to give a little bit of backstory, I grew up in Maine, and a lot of the doctors that I had growing up were actually DOs. And so from a really young age, I saw osteopathic doctors treating, and I'll talk about what that means in a second, treating my parents, treating me. And I knew that was something that I wanted to incorporate into my life if I were to become a doctor. And when I made the decision to go to medical school, I only, I was looking at DO schools and knew that's what I wanted to do. So osteopathic medicine is there's two branches in medicine, really. There's allopathic and osteopathic. Allopathic is the MD, medical doctor, that everyone is pretty familiar with. And then DO is Doctor of Osteopathic Medicine, or Doctor of Osteopathy. The principles started somewhere around the 1840s, 1850s, and then after the Civil War was when it really picked up. Dr. Andrew Taylor Still was the founder. First school opened in like the 1890s. And really it was born out of, back then the medicine that was treating infectious disease, anything was really awful. I mean, it was essentially poison, or alcohol, or a combination of mercury and poison and alcohol. And it wasn't working very well. So he looked to the body and looked for solutions. So he made major connections between function or structure and function, all the way down to, the blood vessels and the nerves that provide sustenance to the muscles in the body and the organs. And so he developed a field of medicine that was different from MD. He was actually an MD himself, and was an MD in the Civil War. And then he developed this field where he would adjust structure to alter function. So he was treating anything from sore backs and sore, wrists and knees to diphtheria and infectious disease, only using manipulation. So, over the years, this has obviously evolved quite a bit. Science has come a long way. Medicine has come a long way. So now in medical schools and osteopathic medical schools, the curriculum is very similar in many ways. We get 2 whole years of teaching in manipulation, osteopathic manipulation, which I'm sure we'll talk about as we go here. But it's just it's an added little perspective on pathology and healing that MDs haven't historically gotten. Although I will say that a lot of the medical schools are doing a really good job of teaching, how to get to the root of the problem and thinking about the whole body. So the elevator speech it's a second branch of medicine. You go to medical school at a different kind of medical school, but then when you go to residency, you can go, I went to Wake Forest, so there's mostly MDs there. There were several DOs as well, but you get training after medical school at a residency program that is either only osteopathic or both osteopathic and allopathic. You can go into any specialty that you want, whether it's neurosurgery or pediatrics or family medicine or psychiatry. And then you can do post training as well in a fellowship. So you may have been to a DO and not even known it, as another way of looking at it.
It all started back in, was it Kirksville, Missouri? Is that right? Or Missouri?
Right, yeah, Kirksville, Missouri was the first. There's a couple of maneuvers called the Kirksville Crunch that are pretty helpful in relieving upper back pain.
You were talking about your differentiation of training from an MD, and you had mentioned the osteopathic manipulation training, which OMT is referred to. Why don't you talk a little bit about that? What is that, and what did you learn? How do you apply it?
Yeah, so it is a way of looking at the body in terms of, like I said, structure and function. So the best analogy I think I've ever heard is if you're building a house, right? Or if you're looking to repair an old house, maybe that's more of an apt analogy. If the foundation is crooked, you can expect that the roof is going to be crooked too. So you can trace kinetic chains through the body. If someone's coming in with a headache, does that just mean that there's a problem with their head, or does it mean that they sprained their ankle 3 weeks ago and they haven't recovered from that injury? And then there's been this kinetic pathway up the body that has resulted in tight suboccipital and upper back muscles, causing tension headaches. So, that's kind of what osteopathic manipulative therapy focuses on. We spend 2 years learning all the different ways to diagnose somatic dysfunctions, which are, specifically diagnosable entities in the spine and the extremities that you can treat to make pain go away, to increase function of the body. So there's a lot of similarities in you'll see some similarities in chiropractics. There's some techniques that are pretty similar to chiropractics. And then in the physical therapy world, a lot of the physical therapists are doing a lot of these, incorporating a lot of these manipulation techniques into their practices very effectively. And so there's a lot of overlap now. But if I were to give someone a treatment who has never been to a DO, they'd probably say, oh, this is similar to when I had that treatment at my physical therapist, or, there's some things there that I had with my chiropractor. And so there's definitely some overlap.
Absolutely. I'll give the listeners an example of my own. I've been kind of going through my journey of late, I've had this kind of hip and calf injury. The calf came around because of the hip. My pelvis was rotated. The one hemisphere rotated internally and was forcing that calf to drive down a little bit harder, and that was causing the calf injury. And so we were, I went to Miriam, my physical therapist, and we determined that there's a strength discrepancy in that side, and that's why it keeps rotating on me. And so we're working on the strength of it. But in the meantime, Beth was using OMT to try to correct the pelvis itself, so it goes back into position, and I don't have that discomfort, which, it wasn't a chiropractic move in which she was trying to pop something or, do a pubic symphysis and bring that back together. It was just working the muscles and moving the muscles in ways that would manipulate the hip back into, or the pelvis back into its position. So that's how OMT can be used. There's a billion different other ways, as you were describing, the neck, the shoulders, the back, using muscle energy to correct something rather than use a chiropractic move to adjust. So yeah, it's very effective, and it's not as, I would say, intrusive as a chiropractic move sometimes. So I kind of appreciate the subtlety of OMT rather than getting on a table and just being like pop pop, So
and I'll say, like, a lot of the it depends on what book you read, but if you're coming at it from an osteopathic perspective, and there's some great books out there about the history of it. Chiropractics, the guy who started chiropractics and the guy who started osteopathy were sort of developing stuff at the same time. And you'll see a lot of similarities in a lot of the techniques. But in general, what I've learned is one of the differences, but again, not a difference with every chiropractor. There's some really good chiropractors out there, and there's some not so good DOs out there too. And so, but in general, what I've learned is it's very much, if you're going to be using high velocity techniques, which is the cracking and the popping that you are, that you're mentioning, it's all about localization. And so, it's about very small movements that are not supposed to be painful or scary. And you're isolating one segment, or, maybe up to 3 segments at a time. And so there's definitely some differences in how we approach, those high velocity maneuvers.
And you're also, though, looking at the body as a whole. As you said, it could be an ankle sprain that's causing this headache, 3 weeks later, it's just had this kinetic chain up. So you're looking at the body as a whole. And as you said earlier, you're using the body itself to try to heal itself.
And that's a great point is, I tell all of my patients who come in for manipulation that I'm not fixing you. I am removing barriers to your body healing itself. And I think that perspective actually helps a lot, because, a lot of people will get kind of sucked into going 30 or 40 times a year to a chiropractor. And it's like, well, I need to get fixed every week. I can't not go every week, or else my body will fall apart. I have no control over that. And it's, well, and that may lead into some of your questions about physical therapy. But, I think that perspective of osteopathy certainly is different.
Right. Yeah. No, you're looking at it systemically, as the body as a whole, which is fantastic, rather than just, is the neck, is there something in the neck that needs to be corrected? And like you said, I don't mean to take anything away from chiropractics, because there's definitely a place for chiropractics. And so I mean no slight to that, that profession in any way. Well, I mean, we can kind of talk about, we'll keep going on so if an injury does, present itself in a patient, but it's coming repeatedly, kind of like what we were just saying, is that, the person feels like they need to keep getting adjusted. Are you more apt to, we kind of just talked about, you're not looking at just the symptoms, you're trying to figure out what's the root, correct?
Yeah. And I think sometimes that is difficult to get to, or you may have an idea of what that is and you end up not being right about it. I have a patient right now that I've seen a couple times who she's very young, very active, probably 35 years old. And, she's having some, left-sided SI pain, that's sacroiliac pain. And so low back pain. And it started when she was pregnant with her second child and never really got better after delivery. And so that's a pretty common complaint for women who have had children. The sacrum and the low back can be really altered by, this, albeit a natural process, but still it can be quite traumatic to the woman's body. So, we've been working on correcting her, sacroiliac joint over the past several weeks. And she's doing well. And I think part of that is understanding what the key lesion is. And that's a word that is thrown around in some osteopathic circles more than others. It depends what school you go to, kind of like it's like Chicago's all about the lumbar. And then, a lot of other people like VCOM is very much about the sacrum and the SI joint, and the pelvis as sort of the keystone of the body. But I think, trying to get to the root of the problem, just like a good, on my family medicine or other sports medicine side of things, like that's important to do too. And so applying those osteopathic principles to, family medicine and sports medicine other than osteopathic medicine, is super important, because you're going to miss, you're either going to put a Band-Aid on it and it's going to come back, or, you're going to frustrate the customer and or not the customer, the patient, and lose a customer per se. So,
well, it's been fun to watch Beth's journey. As a doctor, she's been practicing for 10 years now, and seeing that when she started, patients would come in and they were just looking for that simple silver bullet, right? That painkiller, we'll call it, to just, dull this pain, just, like make it go away, just give me the medicine that will. But, she started with, using the OMT to alleviate back pain, neck pain, headaches, and those patients were so much more appreciative that they didn't have to take that medication. They could just, I didn't realize that, that was what the problem was, that there was some kind of malalignment in the body. Do you see that type of thing today as well?
No, absolutely. And I think that gives the patient a lot of hope too, that it's not something that they have to take medicine for. And sometimes it does take some convincing. I have another patient who's unfortunately has been on narcotics for decades. And she's actually not my patient per se as a family medicine doctor, but she's come to me for osteopathic manipulation. And I had a frank conversation with her up front, and I was like, we're going to have a lot of challenges with you being on this medication, because you're going to have more pain, because that's the way this medication works. It upregulates your pain receptors, and therefore you need more of that medication to keep the pain down. And she understands that, and she's actively trying to come off of it. But the fact, and I was really expecting this first treatment to just not go very well. And I was like, this is going to be a tough patient. And I don't think she had an immense amount of relief right away, but her response to the treatment was so positive, and it was just so nice to I think she just was realizing suddenly that my hands on her, and someone actually trying to fix the problem. Getting back to your question, was buy-in for the patient, and if there's any kind of placebo at work here, then let's do it. So I think that it's a really important point.
I don't think, and that's, point of the podcast here is that people don't realize that this option is available. And so, I think this is great that, you can expound and say as much as you want about, what you do, how you do it, what you try to resolve, how you resolve it. goes deep into detail, because I mean, people are interested and want to know, what other alternatives to just taking like a painkiller, or so, because it felt like that's what the solution was. Like when prior to knowing that DOs existed, when I had an injury, it was like, here's some painkillers, like just take this and take 2 weeks off, like
Right.
as a runner, that's not what I want to hear, I like, especially if it's a recurring injury, like we were talking about earlier, like I don't want that to come back. So, but let's talk about the sports medicine side of things, because you're also, as you were talking about with CAQSM, you have the sport, you have the sports medicine background too. So, can you define that role? What is your role as a sports medicine physician?
Sure. So, and sports medicine physician is actually the newly minted title from the American Medical, the AMSSM, the sports medicine governing body that sort of we look to. There's orthopedists who are surgeons who can go into sports medicine, and then there's primary care sports medicine, and I think the reason why it changed to sports medicine physician was because there's a lot of folks who are coming from different realms, like emergency medicine and physical medicine rehabilitation, going into these fellowships for sports medicine. So it's an added year that you do after. Usually it's a family medicine residency, but it can be emergency medicine, PM&R, pediatrics, internal medicine as well. And you do a year of training. I did mine with Aaron Vaughn and Jess Knapp at Mayhec. I'm going to turn on that light there. It's focusing on musculoskeletal medicine, injury prevention, treatment of injury. This is all obviously non-operative. But there's also, in the past 10 to 15 years, there's been a huge focus on ultrasound and musculoskeletal ultrasound as a way to diagnose or help you diagnose certain problems, musculoskeletal problems, and also to help guide interventional therapies such as injections or needle tenotomies, different therapies that you can use to achieve your goals. So it's a year, and you take a test at the end of the year. If you pass the test, you get the CAQSM, really most people who do it, who are coming from family medicine, I forget the actual percentages, but a lot of people continue to do family medicine. There are some folks who decide to completely not do family medicine, and then they just basically act like a non-operative orthopedist. And a lot of those folks will end up in ortho offices and doing great work, because they still bring that perspective of family medicine, which of all the specialties really focuses on the whole patient, because you have to know the whole patient. But they end up working in non-op ortho and sort of collaborating more with orthopedic surgeons on a daily basis. But the fellowship training and what we do also incorporates things like nutrition, malnutrition in athletes, which is a huge thing, female athlete triad, energy deficiencies. There's a focus on fracture management and non-operative fracture management, and then a huge part of the training is about how much do we take care of and when do we refer. And so I think that's a really important part of the training too, because a good sports medicine physician will refer later, I feel like, than a lot of other providers, because they can take care of a little bit more, but also the referrals are nicely set up, for the subspecialist to deal with. I think I answered your question.
I'll tie my personal story in there, but how much would you say that your role as a sports medicine physician crosses over into physical therapy? Is that still a separate entity, or do you still do maybe a little bit of physical therapy in suggesting maybe some exercises that they could do or some stretches? Is that within your wheelhouse, or do you refer out for that?
That's a great question. I think I want to, be upfront and clear that, like, even though I have maybe more musculoskeletal training than, some folks because I did a fellowship, it's still completely different from, not completely, it's very different from what physical therapists go through for their training. They're doctors of physical therapy. I think a lot of patients don't realize that they have their doctorate. And so I don't pretend with my patients to know everything that a therapist knows. And I think that that's really important when you're trying to get a patient better, is not overstepping your scope of practice. But if it's something that's pretty finitely diagnosable, like carpal tunnel or de Quervain's tenosynovitis in the thumb here, some tendonitis in the thumb. There are some very, very specific exercises that are sort of pre-prescribed that I can recommend for the patient to do. But I will very much often refer for more complex cases. Low back pain by nature is complex. And so I try to get most of my patients even if I'm treating them with OMT, I try to get as many of them as I can into physical therapy. So I think it depends if I prescribe like a home exercise program for them, it'll be a pretty simple problem, that or the patient just doesn't want to go to physical therapy yet, and I'm going to try to create some buy-in by having them see that they can actually improve with some exercises. So yeah.
And so it's just knowing your boundary and knowing where your role ends and where physical therapy, or if they need to go to an orthopedic surgeon, where that boundary.
Right, and I communicate a lot with, and that's something I really learned from Aaron and Jess, actually. The importance of communication with the therapists is so key in developing those relationships, because you can talk on the phone about these patients and suggest to each other what might be a nice next move, or the therapist may come back at me and say, we've brought him to this point. I really think that for his Achilles tendinopathy, I think some, a prolotherapy or PRP would be really effective at this point. And it's a nice team-based approach to care.
That's cool. So Dr. Judkins here is referring to Aaron Vaughn, who is another sports medicine physician and family doctor as well. He took the family physician route. Dr. Vaughn is going to be on the show here coming up. He's another guest we'll have. He is my primary care physician and my sports medicine physician as well. When I was injured last year, a lot of people remember right before UTMB, I had a knee injury, and I went to see Dr. Vaughn to figure out what was going on, because I had this pain and it just wouldn't subside, and I don't like anything that hurts my knee. So Dr. Vaughn used the ultrasound imaging within my knee to see what was going on, if there was something that was causing this irritation. And sure enough, based on this image, he could tell that there was some calcification of my patellar tendon, which was annoying the patellar, the kneecap itself, and then also causing fluid to build underneath the kneecap and causing that irritation and pain that I was having. So we had a course of action, which obviously it got me going, and I got through UTMB. So but it was great to be able to have a one-stop shop. I didn't have to go anywhere else. It was like Dr. Vaughn was able to diagnose, assess, and remedy it all in house, which was fantastic.
That sounds
Well, there's also been cases where he sent me on to Miriam, my physical therapist, and said,
right,
this is what it is, and she'll be able to take care of you in this situation. So yeah. So, and I mean, having that dual background, though, I mean, you can help athletes in a number of ways. I went in for something completely different. I was having a completely separate issue. And he kept coming in the room and saying, "Do you ever feel like your heart skips a beat?" And I was just like, you've asked me like 3 times. Should I say yes? Because I I not that I know of, but so anyhow, he sent me to a cardiologist. And I walked in and I was probably the youngest person there by at least 40 years, and everybody's looking at me like, are you in the right spot? So, I had a echocardiogram, and I have the enlarged heart, the endurance athlete's enlarged heart. So I was getting that strange, rhythm in my heartbeat because it just takes longer for it to fill up with volume and then release, so I had that thump, thump, rather than the thump. So wow. It was neat that I could have that assessment there as well, because I went in for a totally different reason, but finding out was also it didn't change anything, but it's good to know that if something presents itself, he caught it, so they can catch other things, which is my point.
I think that and that brings up a good point that I like to point out to people who are inquisitive about this is the two inform each other. The two fields inform each other quite a bit. A great simple example is someone who wants to lose weight and lower their blood pressure, for instance. That's family medicine role here. And then all family medicine doctors are trained really well on how to coach patients on how to do this and make suggestions, refer when necessary to dietary, to nutrition or whatnot. But let's say that you're trying to lose weight and you're exercising and you hurt your knee. You can use this a little bit of added training, whether it's osteopathic manipulation or the sports medicine side, and using things like an injection. Although you can make the argument that a steroid injection is killing the pain, and what else is it really doing? But it's also getting you to a level where you can do the therapy and that you can strengthen the appropriate muscles and you can actually stay active. And so at times, you can be creative about your treatment regimens and help people be more active, help people stay pain-free so that they can achieve their other goals in life, which is, losing weight and lowering their blood pressure, for instance. So I really do think that they, one makes the other better. And whether you're a family medicine doctor who just has an interest in sports medicine, or whether you're a sports medicine doctor who also sees primary care patients, I think that, that's just a really important relationship.
Absolutely. And I should note that, when I went in for my knee, he mentioned that, a cortisone injection into the knee, it could be a last ditch effort, for me to use if I was still having that pain. We could drain the fluid off the knee and take a cortisone injection, but he wanted to try other steps first. So that's what I really appreciated, was the fact that it wasn't the go-to, like I've been to doctors that are just like, let's get to the cortisone injection. I'm like, is there any other way? So I appreciate that the education that you all have received does not put the cortisone injection as the primary go-to, because obviously there are other side effects that cortisone presents, but it's so having that combination, like you said, it's great, because you can I can see you as a family physician, but I can also see you for a sports related injury. It's a nice tie. So and I have Kyle 5 miles from my house, so
right off of Boylston Highway in Mills River.
Yep, he is 5 miles from my house here in Mills River. So, let's see. So we talked about how there can be a team approach with PTEs and such, and so let's talk about more of the we were talking earlier how you approach medicine holistically, and so how can we as athletes live our lives with a more holistic approach? What are some things that we can do to be more holistic in our lifestyles?
Yeah, I think that the first place my mind goes when I hear that question is to try to achieve simplicity, and that's so much easier said than done, of course. But I think holistic. What does holistic really mean? It means, I'm sure we could look up an actual definition here, but to me, it means really incorporating, as a doctor, incorporating the whole picture. So whether that's, the patient who is a single parent and has to work and now has to figure out how to deal with, COVID and kids not being at school, or, whatever those stressors or family tree or predisposing conditions present. How do I take that patient now and apply the appropriate treatment? So it's not going to be different it is going to be different for everyone. It's not going to be the same template. You can't just apply the same template to every single person. So when we talk about athletes, same thing goes. You're a completely different beast than most people, but and I want to come back to that story that I have. I have a good story about you that you may not know, but when you're talking about athletes, their goals are going to be so different. Their past experiences with injury, their past experiences with training are going to be really different. So when I have someone come in who's an athlete, one of my most valuable questions is, has anything like this happened to you before? Or what other injuries have you had? How have you dealt with those things before? Do you go into a dark hole of depression, or are you pretty okay with doing what you need to do to deal with it?
Yeah.
And how are you with taking time off? Is that something that you want to do, or are you going to basically not do what I recommend? So I'm not going to, someone who has a race in a week, who's at, for instance, your level of running, unless it's like a broken bone. I mean, I'm probably not going to say, well, you just can't run anymore.
Right.
It's like, you might as well just have not seen that patient. Like, that had negative help for that. And yes, you're probably right. Not running for the rest of your life may decrease your knee pain, but that makes no sense. So, for Aaron Saft, what is that whole picture? For Kyle Judkins, what is that whole picture? They're going to be very different things. And that will completely change how you approach that patient's injury. And I think the emotional component of that, which is another added benefit of the family medicine training, is huge. Because people have a lot of emotional attachment to their bodies, and pain can be very scary, just based on what it could mean for their future athletic endeavors, or just the fact that there's pain and you don't know what it is. So, yeah.
I mean, within coaching, I like my athletes to look at everything within their lives. We keep hearing article after article and podcasts that talk about stress. Stress is stress. Running is stress. Your kids can be stress. Your work can be stress. Everything we have, it adds up. We keep adding all of this stress. So I want them to look at that as the big picture, right? It's how much stress is coming from the outside. Can we tolerate more training based on how much stress you already have in your life? Is that tolerable for your life, or are you going to shut down? Is your body going to fatigue too much because you've had, too much stress outside of running? And we try to increase your running. Now we're adding even more stress into the system. So, beyond that, we want to talk about, how much sleep are you getting? Are you getting enough sleep? How is your nutrition? Are you eating the proper amounts of protein, carbohydrates, getting in all of your nutrients and vitamins? And I've had Jake on in the past. He's a registered nutrition, he's a nutritionist, excuse me. He's a nutritionist, and he's talked about this type of stuff, and he's helped a number of my athletes. But nutrition is a huge component, as well as hydration. All of these factors, when we talk about, a holistic approach, when we talk about, training in life, like all of these factors have to come into it. Are you taking care of yourself in, stretching, foam rolling, all of those little ancillary things, strength training, all of these components, they form the system, and they form the athlete. And as you said, no athlete is alike. I can't train, the athlete A the same as athlete B, because, if I gave the same strength training protocol for athlete A, they may not be able to respond as well as athlete B. So, it's when we look at all of this stuff, it's looking at the whole system. And, so for my athletes and for anybody listening, you have to consider all of those. And having a physician such as yourself in your life is a valuable resource, because, if something comes along and it's, it doesn't have to be injury related. It could be anything. You can see you, and it may correlate to your athletic life. But
yeah, exactly.
That's
great. I love
it.
It's like you're married to an osteopath. I don't know.
Yeah, I've learned a lot over the years. So let's talk about some of the injuries here, which some of us. Well, okay, all of us, we tend to run through an injury, or what we'll call a niggle.
I had not heard the term before. I had to look it up. I know you
did not know that. We refer to a what we don't want to appropriately term injury. We refer to it as a niggle. We have this niggle that's bothering us. At what point, where is the line that we should draw in which we come visit you? What signs should we look for that say, all right, this is getting beyond the point of, I shouldn't potentially be running on this or running as much as I am, and I need to come see help?
Yeah. I think the easy answer, but may not be the best answer, is going to be, and I'll expound on that. But I think that, if you get that different kind of pain, and most people who are athletes, and maybe people who are not yet, but are getting into it, they may need more coaching. But in general, those folks are going to be a little bit more cautious about pain. So when you're talking about more elite athletes, or even just really active people who enjoy working out and exercising, there's this little switch that goes off that, that the pain is not a good pain. I think to expound on that a little bit, and to give a little bit more objectivity to it, there's certainly pain that will go away as you run and then won't really come back. The little tweak in your ankle, or your anterior hip, or, the low back, that sort of works itself out. And I think if the pain, if we're talking about a run, say you're going on a 6-mile run, and, the first half a mile you feel pretty good, and then you have a pain that starts to nag you, let's say in your Achilles, your left Achilles, and you run through and you're like, all right, usually this kind of goes away, let me just keep going a little bit. If it just keeps getting worse, and it's changing your stride, it's changing your mechanics, I think that's an important thing to realize. And that's when you should probably slow down and see if the pain goes away, or stop and walk. Or in my case, which I should have done, call my wife to come get me, but I didn't, and I had a calf injury. But, so I think that if it's changing your mechanics and you are literally hobbling through your run, then that's a good point to realize that you're probably going to be doing a lot more damage. Now, the other side of this is, we always kind of joke in sports medicine, but not really joke, that nerve pain and tendon pain are two kinds of pains you shouldn't push through. And so nerve pain is a little bit more difficult to understand for a lot of people, but it's that kind of like burning sensation that may shoot down from your back into your foot. But then tendon pain is, basically pain in a tendon that feels kind of like a sharp, may feel a little bit swollen or hot. It tends to get better as you warm up, may even go away, and then at the end of a run or a bike or whatever you're talking about here, it tends to, when you're done, it tends to come back twofold. So if you notice that cycle in your workouts where you're like, all right, my Achilles always hurts in the beginning of the run, then it goes away, and then at the end of the run it's fine, but then like I sit down and have a beer and then stand up and it's like really bad. That's another signal that like, okay, you probably need to address this. So I think the major thing though is if your mechanics change while you're exercising, that's a good signal to turn back. And then if you're experiencing that kind of cycle of pain where, whether it's a tendon or not, whether the pain is coming back worse than it was before your run or before your exercise session, that's probably not a good trajectory you want to be on.
Right. Yep.
But you asked a great question, and this is like the holy grail of sports medicine, is like, if I can predict that this pain that you're having right now is going to become a major problem, then I'll be on Oprah. But coaches are often they've gotten a lot better about this, I think, in some of the big box sports like football and baseball. But working through that pain, the things that some people have played through, pushed through by a coach who has no medical training whatsoever, So, but still, even when you're talking about an individual athlete, like a runner, they usually want to push themselves hard, and you kind of say, all right, well, that pain will go away, that'll go away, or it's not going to be a long-term thing, it's fine. And oftentimes it's not, so you got to pay attention to it.
Yeah, well, it's. I have an example. Just today, I had a conversation with one of my athletes. Has had knee pain, but was told, by his physical therapist that was okay to train, because we weren't at high volume or doing really anything too strenuous workout wise, but that it was okay to keep training. But the pain persisted, and I think it persisted too long, and it's hard. I guess it's hard for myself as a coach to say, should we take time off? Because the athlete doesn't want to hear that, obviously. I've understood my role, which is kind of part of the next, question we're going to talk about, is that, I'm not a doctor. I realize that I'm not one here to assess injury or whether a person should be running through. All I can say is that, throw some ice on it, and get like a professional opinion. Like, is it something that you can keep training, or, should you take time off? There's times where I know that the injury is like, all right, let's take some downtime, probably should get it assessed just to make sure it's nothing worse than what, we can see what it is right now. But often, and this is, the question I had for you was, there's this, there's this thing called WebMD. And everybody seems to have access to it, and everybody seems to have gone through medical training, because I'll get these self-assessments that they have this rare injury that only 1% of the world population ever has, but they have it. So I can't imagine that either self-diagnosis through WebMD, or seeking out your group on Facebook and asking them, hey, I've got this spot on my knee, and it's this circle right here. What do you think it is?
Coming into it. Yeah.
What advice would you have to our WebMDers and Facebook askers?
Yeah. Well, I think first of all, the experiences that you have as an athlete yourself and other athletes that perhaps interact with your athletes are definitely valuable. And I think that you have a really healthy perspective on that. Like, okay, knee pain. I've had knee pain before. But you understand enough about sports medicine to know that not all knee pain is the same just because it's the knee, right? There's lots of different parts in the knee. So I think, first of all, it's the getting almost some injury camaraderie a little bit can actually be somewhat helpful if the person is not playing doctor or physical therapist. So I think the other side of this is that if there's an injury that is changing the way you're exercising or your mechanics, or is really bothering you emotionally, then sure, do your research, come up with a list of questions based on that, and whether it's WebMD, whether you have access to other resources that perhaps are a little bit more rigorous, then bring them to a professional. You can start with your family med doctor. Like, the family medicine doctor is trained, very well in musculoskeletal medicine, and so like if it's something that they feel strongly that they can handle, then that's something they will handle. And then otherwise, maybe you'll get to a physical therapist, maybe they'll get to a sports medicine doctor, or maybe an orthopedist. But I think coming up with those questions from WebMD can be helpful, because you get a sense of what's out there on the menu. But I think you have to approach it with a healthy bit of skepticism, because I think cancer is always going to be on that list of WebMD, and that's definitely not always the case. I think if you want to look at it, it's not like you should avoid it at all costs. It's not like wrong information. It's just so broad and so nebulous, it's difficult to apply the URL entry of knee pain, to your situation. Yes, it could be patellar tendonitis. It could also be a patellar fracture. It could be an ACL injury. Those are such different things that are managed so differently, that I would say use it with a huge grain of salt.
Sure. Now, I would be completely insensitive to a number of people, and I've heard this quite frequently, is that that they can't afford to see a physician. Are there resources out there that you know of that can help people to have an appointment and get taken care of?
Yeah. The first thing I would say is call around to the different offices. I know that a lot of folks will have financial assistance programs that are pretty. Some of them are pretty good. I know Pardee has one. I know Mission has one, or HCA. Mayhec has one. I think maybe through Mission, but definitely call around and check with the doctor's offices. Don't just assume because you don't have a good paycheck right now, or you don't have insurance, that's not something that to me. And this is a whole different conversation. Healthcare is a right, but I think that if you're looking for specific resources to help you for musculoskeletal problems, that maybe you're looking for, like, maybe I can do some exercises at home for like my low back pain, or and it's pretty nondescript, I think I would still recommend trying to get some sort of medical opinion. But if it's just like the run of the mill, like this has been hurting me for like 10 years and I just want to try something at home, the American Academy of Orthopedic Surgery, so AAOS, has some really nice online PDF format sets of exercises for pretty much every body part. They have ones for the low back, the neck, wrists, for carpal tunnel, ankle. So that's a good resource. If you just Google AAOS and then the body part that you want to look at, we use those a lot in clinic for home exercise programs.
I'll put that in the notes.
Yeah. And then the other one for specifically that I use a lot that is pretty, and all these have like really good cartoon pictures or actual pictures, and then a very detailed explanation of how to do them, and then reps and number of times per day or whatnot,
Okay.
The other one is Princeton University ankle rehab program, and for sprained ankles. So if you have a sprained ankle that you've had this before, it's been pretty manageable, but you just I would still recommend my waiver here is still recommend getting it looked at if you can. But if you're at home and you're like, I don't have any other options, I need to rehab this ankle. You've iced it, you've taken ibuprofen, you're trying to get back to running or whatnot. Princeton University ankle rehab program is a really nice. If you just Google that, they have a really nice rehab program that's very, very well depicted.
Great. I'll add that to the show notes as well.
Yeah.
Very cool. All right. What was your story? I have to hear this.
I think you'll probably remember it. Actually, I was a fellow. This was at the Shut-In in 2018, and we were covering the Shut-In, which is I'm sure your listeners probably know what that is, but it's a 17.8 or 18 mile basically uphill race in Asheville area up to Mount Pisgah, and it's grueling. And I was just like walking around and driving that day. And we were at about the halfway mark, and you and your dog were coming down from the finish side. Yeah. And it must have been like 9 o'clock in the morning or something like that, maybe. And Aaron Vaughn was there, and it's like, oh, this is Aaron Saft. He, is the guy with FootRx, and he's the runner that we've been talking about. And I was like, oh yeah, great. What are you doing? Because you were wearing your running stuff. And you're like, well, I'm doing a quick out and back. I was like, oh, what do you mean out and back? You were running the Shut-In twice in one day, and that's when I knew that I was out of my league.
Thinking about it, that's what you mean. I wasn't right. Great.
And I was like, I was actually more concerned about your dog, but apparently he can take it. So.
Oh yeah, Miles. Yeah, his name Miles for a reason.
That's right.
Yeah, he's fantastic. No, and I had a bunch of athletes running it as well, so we were. I was checking on them too. Sure. No, that's right. I do remember because I pulled into Ben Creek Gap is where you guys were down by the tunnel. So you remember that? Yeah. Yep. That was a beautiful day. It
was gorgeous. And actually, the other story is actually about your wife. I don't know if she knows this, but actually, I think I did tell her at one point. It was a meeting last year at Pardee that I mentioned it to her. I was mountain biking with, I think, Aaron and one of the athletic trainers, Michael Hodges, and we were like finishing up the mountain ride in Pisgah, and we passed her, and Aaron was like, oh, that's Beth Saft. That's Aaron Saft's wife. She's a family medicine doctor. I'd already met you. He knew that. So I was like, oh, cool. Hey, Beth, how's it going? She was running with Miles. And we finished the ride. Like, we had another, I'd say at least mile after we saw her. And we had like literally just gotten off our bikes, and she pops out of the woods. And I was like, are you kidding me? Like, what? Who are these people? I mean, we were on mountain bike, and she was like basically right behind us the last mile or two.
Yeah. We're very fortunate to have a great backyard. Those trails are like 3 miles from our house, so it's.
Oh, really? Great. Oh, that's fantastic.
Yeah, it's such a great resource. Well, Kyle, like that, it was great. That was a lot of fun. Really enjoyed our conversation. Thanks for being on and sharing all this information. I hope the listeners have a better perspective as to what osteopathic medicine is. And once again, we'll probably talk to you in the future and hit you with some hard questions.
Yeah. I'll be prepared next time for hard questions. Thank you so much, Aaron. I really appreciate it. If anyone wants to reach out to me, I'm sure we can arrange that through your notes. I'm happy to answer any questions that may come up.
Sure. If they want to find you or reach out to you, best way to do so, look you up on the Pardee website, or?
Yeah. So my office is Pardee Family and Sports Medicine. It is right next to the Ingalls in Mills River, right on Boylston Highway and the intersection of Boylston Highway and North Mills Road as you're going into run or mountain bike. You can look me up on Pardee website, and you'll or just Google me, and you'll see the address and the phone number.
Cool. Great. Yeah. So if anybody has any questions, they can reach out.
Absolutely. Thank you so much, Aaron. I really appreciate it. It was fun.
Absolutely. Thank you so much. Once again, thank you, Kyle, for coming on here. He's he shared with us some resources, and again, I'll put those in the show notes as well as some of the other things that I talked about in the intro. It was a great conversation. One of my next guests is going to be Dr. Aaron Vaughn, who is an MD, but he is also a sports medicine physician. We'll be talking about some of the things that MDs have learned, and but also some of the current trends that we are seeing in sports medicine today, and some things that can benefit all of us in our running and dealing with injury. Just current trends. We'll be talking about all of that, and I'm also going to be talking again with my physical therapist Miriam Saloom of the Runner's Mechanic. We'll be talking about the Achilles tendon and the health of the Achilles tendon, how to keep it strong, how to keep it moving and functioning properly, I should say. So look forward to that conversation. And next week I'll launch Aaron Vaughn's podcast, and then probably the following week I'll have a little bit more of a chat, and then I'll add in Miriam's conversation as well. So once again, guys, thank you for listening. Please subscribe to the podcast. Leave a review on Apple iTunes if you would. That helps others. If you can share it with some friends, again, I sincerely appreciate the support. Really, I'm enjoying this platform, enjoying learning myself and having these conversations. So thank you for this opportunity. Don't forget to follow me on Facebook, MR Runningpains Coaching, and as well as on Instagram, MR Runningpains, my YouTube channel, Aaron Saft, and let's see, you can follow along on Strava again, follow along on my journey. Again, I'm Aaron Saft on there, and Aaron Saft, MR Runningpains. So until next time, my friends, thank you for sharing this time with me, and we'll talk to you soon.